You're listening to the Pre-Hospital Care podcast on the Medics Academy Network.
Welcome back to the podcast. Today on the podcast, we're looking at the most dynamic and ever-changing landscape of club drugs and novel psychoactive substances. In the episodes we are just about to listen to, we hear from both Owen Bowden-Jones, who's a consultant psychiatrist, and Dr Caroline Copeland, who is a senior lecturer at King's College London. We look at the ever-changing landscape, look at MDMA, ketamine, GHB, synthetic cathinones, nitrous oxide, synthetic cannabinoids, and the ever-changing landscape around designer drugs and how these can affect both neurologically, cardiovascularly, and psychiatrically on patient presentation. And we also look at presentations with severe agitation, hypothermia, excited delirium, seizures, cardiovascular collapse, and or life-threatening toxicity related to club drugs and novel psychoactive substances. So the first conversation is with Dr Owen Bowden-Jones. He is a consultant psychiatrist, addiction specialist, and one of the UK's foremost experts in club drugs and NPS. Owen has spent decades working at the intersection of addiction medicine, psychiatry, toxicology, and public health, helping clinicians really better understand the evolving risks associated with these substances, whilst also shaping national guidance and policy. So, in a more recent episode, we spoke with Dr Caroline Copeland on the ever-changing drug landscape, and we explored in that conversation, and one you're going to hear, really around the increasingly potent synthetic opioids and the emergence of entirely new psychoactive compounds that are challenging both for clinicians and public health alike. So the conversation, both with Caroline and with Owen, provides really a broad overview of today's drug landscape. It gives us really a new look at club drugs and novel psychoactive substances. So looking at how they work, so their pharmacodynamics and pharmacokinetics, but also how they present clinically and how we can manage them safely and effectively. So just to say that the conversation with Dr Owen Bowden-Jones was recorded in September 2020. Now the information is as relevant today as it was when it was recorded, and when I was going through the edit, I realised that absolutely it's a relevant conversation, and the information in that episode is fantastic. He also points to the Royal College of Psychiatrists Learning Hub, or e-learning, and they have a module called Neptune module, which is an introduction to club drugs and novel psychoactive substances. So I'll put the links in the show notes to that. It's a fantastic online e-learning platform with CPD attached. It's free, and it was published in April of 2022, and it's a fantastic resource to go away and look at. The conversation with Caroline was recorded in February of this year. Her online empirical research is also wide-ranging and fantastic to look at, and I put links in the show notes to her profile at King's College London. It's really worth going away and looking at some of the empirical literature she has published as well. Okay, I do hope you enjoy. Please, as ever, feel free to rate, review, and indeed subscribe to the podcast. We'll see you again next Monday. I hope you learned as much as I did from these conversations. They were extremely informative, both at time of recording and on this previous edit. Okay, thanks, and we'll see you again on Monday.
There are 3 or 4 different terms that are bandied around, and they do overlap, and they do create some confusion. So I think it's really worth going through this in a bit of detail. So novel psychoactive substances are essentially psychoactive substances that sit outside of international drug laws. And those were also sometimes called legal highs. So because they are technically legal, they were at some point sold and marketed as legal highs. But that term now, legal high term, is not used so often. And then we've got another group of drugs called club drugs. And these are things like ketamine, MDMA, GHB. Now, these drugs are under international control. But obviously there's an overlap sometimes between people who use a mixture of novel psychoactive substances and club drugs. So the terminology in this area is really quite confusing. And the way that certainly I try and help people navigate this is to think perhaps not so much about the legal context, but to try and think more about the psychoactive effect. And the way I do this is I suggest that people try and think about the primary psychoactive effect of a drug, and dividing that into drugs that are broadly stimulant, broadly sedative, and broadly hallucinogenic. And by taking that approach, the majority of both the club drugs and the novel psychoactive substances can be put in one of those categories. Broadly speaking, if you look at a time frame of maybe 15 to 20 years, then the number of people using psychoactive drugs has actually been falling fairly steadily over that sort of time frame. If you look, however, over a 5-year time frame, what we've seen is an uptick in use, particularly in younger people, over the last couple of years. And obviously, a couple of years is a short time to make comments about a trend, but we're very concerned, really, about the increase in drug use by younger people. And by younger, I mean people under sort of from their mid-20s down.
In the clinic that you run, what are the sort of current top 5 drug abuse substances that you see in the clinic?
Well, the clinic we run is an interesting one because it has very strong links to our local sexual health services. And we, for example, run satellite services within the sexual health services. The other thing that's unusual about our clinic is that we also run services into local student health centres. So in a way, we're already accessing younger groups than perhaps other drug services might do. The other thing that's unusual about the club drug clinic is that we don't treat drugs such as heroin, crack cocaine, and alcohol. So if you look across the UK at drug treatment services, you will find that the majority of people are using heroin, crack cocaine, and then alcohol is probably the third most commonly used drug within drug services. And you'll also find the typical age of patients attending those drug services will probably be in their 40s. And these are probably people who have started using heroin probably 10, 15, even 20 years ago. And so they'll be quite long-standing users who will typically be going to the services for opioid substitution treatment. Where the club drug clinic is really very different is that we explicitly don't treat heroin, crack cocaine, or alcohol if that's the primary drug problem. And instead, as the name suggests, we have set ourselves up as a service that treats everything else. And so the drugs that we tend to see are the club drugs, but also, interestingly, quite a large number of people who misuse prescription medicines, things like pregabalin, Ritalin, and the benzodiazepines. And so our top drugs are things like GHB, methamphetamine, ketamine, and prescription medicines. So a very different using profile to what you might come across in a traditional drug service. The prevalence of use of a particular drug does not translate into harm. So different drugs have different levels of harm. So if you look at a population level, the most commonly used illicit drug in the UK by far is cannabis. And that's followed by cocaine and MDMA. So if we then look at the treatment services, as I've mentioned, the top drug by far is heroin, followed by crack cocaine. So what we're seeing is relatively small numbers of people at a population level use heroin and crack cocaine, but the harms they accrue from those more harmful drugs leads them into treatment. Whereas at the same time, many, many more people use cannabis, but as a drug that's less harmful than heroin, we're seeing far fewer people actually requiring formal structured specialist drug treatment for their cannabis use. And a good recent example is nitrous oxide, which appears to be a bit of a fad at the moment. It's hard to walk around London without seeing the small silver sort of capsules on the floor. And so there's been very significant increase in the population prevalence, largely by young people, of nitrous oxide use. But what we have not seen is our clinics filling with nitrous oxide users, because the harm of that drug is relatively less than many of the other club drugs that we see. Well, if you look at the prevalence data, you're absolutely right. What we're seeing is an aging cohort of heroin users who began using heroin in the 80s and 90s and have continued a relapsing and remitting course during the past 20 years. And typically that's been on and off opioid substitution treatment. Now, those users, obviously some have recovered and don't need treatment anymore, but a significant number have continued in treatment and found that a very difficult drug to conquer. What we're not seeing is large numbers of young people using heroin. In some ways, heroin, I suppose, has developed such a stigma among young people that they do see that very differently to some of the club drugs. So, for example, I will often meet someone perhaps in their 20s and ask them which drugs they'll use, and they'll very comfortably and casually tell me that they use MDMA and ketamine and amphetamine sometimes and benzodiazepines. And then when I mention heroin, they look at me in horror that I would even suggest that they might be the type of person who uses heroin. So there does seem to be a very sort of unusual sort of internal stigma between drug users around specific drugs. And certainly what we're seeing is we're not seeing younger people desiring or beginning to use heroin at the moment. Now, of course, one of the complexities around this field is that the drug markets are very dynamic. They change very, very rapidly. Things come in and out of fashion quite quickly. And so it's very hard to predict the future. So what I'm not saying is that we don't need to worry about heroin anymore. Heroin is one of the most destructive drugs as we can see from our current drug treatment population. So it would be very, very important not to take our eye off the ball with heroin. But at the moment, it does seem that if you're focusing on younger people, then we need to be thinking about different drugs.
Absolutely. So Owen, I'd like just to drill down into the few subdomains that you mentioned earlier, if that's okay. So the main groups, as you mentioned, being sort of the sedatives or dissociates, the stimulants, and then maybe the hallucinogens or the sort of synthetic cannabinoids. So let's maybe just take the sedatives first and foremost.
Again, maybe a good way to frame this is to think about how the club drugs and the novel psychoactive substances sort of came about, and particularly the novel psychoactive substances are really an attempt to mimic the effects of traditional drugs. And so for each traditional drug, you are now finding a synthetic equivalent. So if we just think about the drug groups, if you've got a sedative drug like heroin, you now have a range of novel psychoactive opioids, which include fentanyl and the fentanyl analogs. If you think about stimulant drugs, a sort of traditional stimulant drug would be something like cocaine. And the newer version, or the attempt to copy it, is with a group of synthetic drugs called cathinones. And similarly with hallucinogenic drugs, things like traditional ones like LSD or magic mushrooms, perhaps, there are now a range of quite potent novel psychoactive versions of these hallucinogenic drugs. So in each case, the novel psychoactive substances are really an attempt to mimic or copy the effects of traditional illicit drugs. Well, what's interesting is that novel psychoactive substances, although they're an attempt to mimic traditional existing psychoactive drugs, what often happens is that the new synthetic equivalents end up being more potent than the drugs they're trying to copy. And so you can end up with these quite dramatic clinical presentations when people use them. Now, the system we have at the moment is that many of these new psychoactive drugs are simply sort of cooked up by chemists, chucked onto the illicit drug market without any testing, just to see whether people like them or not. And the ones that people perceive are too strong, they tend to disappear off the market very quickly. But you do end up with these situations where you see clusters of acute presentations where a new psychoactive substance has been sort of released onto the market. A group of people have taken it and ended up with often catastrophic health harms. To the dealers, they don't really care. They're just sort of testing out a new product to see whether people like it or not. But often it's the pre-hospital setting which is sort of is the first port of call to deal with these clusters of acute presentations. And as you mentioned, one of the common features is really marked agitation, psychosis, distress. People can be really very unwell at that first point of contact with health services. Well, the Frontline stretches even further than that, actually. So you mentioned prisons, which are very important. So custodial settings have seen a particular issue, as you mentioned, around a group of drugs called synthetic cannabinoid receptor agonists. And you mentioned the word SPICE, which is the term that's often used to describe them. And I haven't actually put that group of drugs into the sedative, stimulant, or hallucinogenic group, because actually that group can have all three effects. And it's very hard, because they're so chemically diverse, to put them in any one of those three groups. So they almost sit as a group on their own and have been causing, as you mentioned, particular problems within custodial settings and with homeless populations. But the health frontline goes further. So it goes as far as, you mentioned primary care. I would add to that sexual health services. I'd also add social services, which are often are contacted when people have had particularly difficult experiences with these drugs. And to be honest, young people can present it in many, many different places. So, for example, student health services are another area that we need to think about in terms of making sure that clinicians have the right skills and knowledge to both detect and also manage harms from these substances.
Absolutely, indeed. So something you just mentioned there, Owen, around the homeless population, and certainly it's been my experience as well that there's a wide array of patients within the homeless population that seem to ingest not only these drugs in single use, but certainly in combination. I want to say combination therapy. I'm not entirely sure it's therapy, but would you say I understand this is maybe a more clinical psychologist question, but would you say there's certain sort of mapping of social deprivation onto drug addiction from cases that you see at the clinic, or is that not necessarily the case?
Well, what we're actually seeing is very interesting, which is we're seeing different drugs being used by different populations. So again, to return to heroin for a moment, heroin has always been associated with deprivation, and the SCRAS, that's the SPICE, as you mentioned, is also very strongly linked to homeless populations. And these drugs are relatively cheap, they're potent, and they are often targeted at people who are particularly vulnerable. What we're seeing is, though, we're seeing patterns of drug use in other groups as well. So, for example, in men who have sex with men, we're seeing specific drugs being used to enhance sexual performance and pleasure. And those are particularly drugs like GHB and methamphetamine. In young heterosexual clubbers, we're obviously seeing the use of things like ketamine, MDMA, cocaine. And so what's happening is we're seeing different profiles of drug use in different parts of the community.
How do these combinations, are there classical combinations that you see, and or more disparate combinations, sort of more on the fringes?
So that's a really good question. I mean, I think the first point that you raise is about polydrug use. And the vast majority of people who come asking for help at our clinic are using more than one substance. Not necessarily in a dependent way, but often in a combination, as you describe. And the problem with this is that, firstly, the more substances you use concurrently, the greater the risk of harm due to interactions. The second thing is that it also makes it more difficult for staff to understand what's going on. So if someone has taken a stimulant and a sedative, they may cycle through periods of being very agitated and alert, followed by periods of drowsiness, then returning to periods of overstimulation. And that can be very challenging to manage clinically, because you're not quite sure what's been ingested. There are some classic combinations. So the first one is alcohol with everything. So alcohol is our most widely used psychoactive drug, and we see the vast majority of our patients consuming alcohol, and will often consume alcohol with other drugs. So alcohol and cocaine is a very particular combination. As I'm sure you're aware, that when those two are co-ingested, they interact to form a third substance, cocaethylene, which itself is a psychoactive drug and can have particularly sort of cardiotoxic effects. Some of the other combinations we see, so a combination we see in what's sometimes described as the chemsex area is GHB and methamphetamine. That's a very sort of commonly used combination for sexual enhancement. We also see in the clubbing scene things like MDMA and ketamine being used concurrently. So within the different drug-using populations, there are common combinations, and those often come with quite unpredictable harms, which is a real challenge, particularly in the pre-hospital setting. So, this is an absolutely critical point. So let's talk about serotonin syndrome first. So essentially serotonin syndrome is a description for when there's too much active serotonin, and there's a range of symptoms present, which can include, but not always include, but can include hyperpyrexia, increased muscle tone, clonus, and agitation and delirium. Now, you tend to see this obviously more commonly when people have taken drugs that release extra serotonin. So these tend to be the stimulant drugs. So what we would typically see is someone who's perhaps used methamphetamine or MDMA or cocaine. And the risks are increased if people are also taking serotonin-boosting medications. So there is certainly a theoretical risk that if someone's taking an SSRI antidepressant, for example, and then takes stimulants on top, then that could increase their risk of serotonin syndrome. One of the complexities about serotonin syndrome is it can present really with quite a range of severity. So the majority of cases, certainly the ones that I've seen, are usually self-limiting. So the symptoms are relatively mild. They need careful monitoring, but within 12 to 24 hours, they improve without significant intervention. But the level of severity can be much, much greater than that. And I'm sure you have had experience yourself of seeing people who, really need very rapid medical care and transfer to intensive care. So it's one of those quite tricky diagnosis to make, because often when you first see someone, particularly in a pre-hospital setting, they may have just taken drugs. So they may be a little bit confused. They may be a bit hot if they've just come out of a club. And it makes it hard. There are a lot of confounders in terms of the diagnosis, but I would encourage colleagues to always bear in mind serotonin syndrome, because it can develop the symptoms and the severity can develop quite rapidly. We have seen over the last 5-6 years a set of changes. So the first change was people going to the internet, and that was either the darknet, which is an encrypted part of the internet, to buy drugs there, or when legal highs were more widely available, people were buying them as research chemicals off ClearNet websites. Over the last couple of years, though, the practices have changed, and people now are very much buying their drugs on social media apps, so things like Snapchat, Instagram, and there is a whole sort of coded lexicon of drug sale terms, which are now used and actually change quite rapidly. It's quite hard to keep up with the different terms. But this really appears to have taken a hold, certainly in our younger users that we see at the Club Drug Clinic. And so in the way that younger people are used to using their mobile phones for everything, really, you buy a ticket, you order a takeaway, drugs have now joined those other activities as, for some, quite a normalized way to order drugs. Now, as you mentioned, the quality control of illicit drugs has never been very high. But what we are seeing at the moment, as I mentioned a bit earlier, was with some of the novel psychoactive substances, that actually these substances are completely new. And so no one has any idea whether they will be relatively harm-free or whether they'll cause catastrophic problems for the users. And that introduces a greater level of risk than we've seen with some of the more established drugs. And one of the problems we're seeing is that some of these MPS are now being missold or substituted or cut into some of the traditional drugs. So things like cocaine, we're now finding are being sort of cut with some of these MPS, simply because it's easier to make. It's easier and cheaper to make some of the MPS than it is to get cocaine all the way from Colombia. So the dealers have a definite desire to use some of these cheaper drugs, but the harms of the drugs are really poorly understood. Because as you mentioned, we spent much of today quite rightly talking about the acute presentations, which, although the presentations might be quite extreme, the majority of them, I think, will fit within the sort of knowledge of most sort of pre-hospital care staff, in the sense they will have seen a psychosis before, they will have seen extreme agitation before, extreme sedation before. What's happening now is we're beginning to see people use these drugs for long enough that we're beginning to get a sense of what some of the longer term harms may be. And so we're seeing some quite unusual things. You mentioned ketamine bladder. So we're seeing a situation where people who use ketamine over prolonged periods at reasonable doses are getting a sort of ulcerative cystitis and presenting with dysuria, hematuria, or polyuria. And these sort of three symptoms, if you don't ask, young people tend not to mention them. Or if they do mention them, they're often dismissed as a urinary tract infection. But actually what we're seeing is quite high numbers of our habitual ketamine users experiencing these harms. And similarly with some of the other drugs you mentioned, HPPD. So this is a sort of ongoing, typically a set of visual distortions that people can get after using hallucinogens, or sometimes other drugs as well. And we're only just beginning to get a sense of what the size of the problem is. And we still have relatively poor understanding of the mechanism of action of some of these harms. So the next 5-10 years, we'll really, I think, begin to understand some of the chronic harms better. But at the moment, we're still seeing so many new drugs come onto the market each year that we're constantly playing catch up, and that, of course, is a challenge for clinicians, but also a terrible risk for users. If I could put in a brief plug, that if you go on the Neptune Clinical Guidance website, there are some free e-learning modules. There are 7 of them. And some of them, there's an introductory module, and then there are modules on acute harms from each of the groups we've talked about, so stimulants, sedative, hallucinogens, and SCRAs. And each of the modules takes about 15 to 20 minutes, so they're relatively quick to do. And as I said, they're open access. We've had about 5,000 staff complete these modules now with very, very high levels of positive feedback. And then the other quick plug, if I may, is that through Cambridge University Press, myself and a colleague, Dima Abdurrahim, are releasing a textbook on club drugs and novel psychoactive substances. It's described as a clinical handbook. It's got lots and lots of case studies as part of the book.
So we're seeing, a shift and the new drugs that are emerging on large are these synthetics, and I think that we're seeing drug gangs move away from plant-based drugs more towards synthetics. So your plant-based ones, your opioids, your heroin, your morphine, your codeine, and your cocaine, things like that, and more towards these synthetics. And I think a reason for that is, well, several reasons, but with plant-based drugs, you need land to cultivate them, you need good weather and water, you need farming equipment. They're also not very potent, so they're quite, you need a fair amount, so they're quite bulky to traffic and to move around without being detected. Whereas the synthetics are easily made in clandestine laboratories, and they're so potent that if you send 100 greetings cards with a gram each in them, some of those are going to get through the postal system, and so they're easier to make, they're cheaper to make, and they're easier to traffic and smuggle as well. So I think that's why it's one of the reasons we're seeing a shift towards a greater number of synthetics emerging. And in terms of the classes that we're seeing, the US has had a problem with fentanyl for several years at the moment, which is a synthetic opioid. And we're starting to see these nitazenes in the UK as well. But we're also starting to see a shift towards some synthetic stimulants as well. So cocaine is a naturally occurring stimulant in the coca plant, but we're starting to see synthetic cathinones and other synthetic stimulants appearing. And I just think that's the trend towards where we're going. And many of these synthetics by design are very potent, which means that the dose of drug which is safe to take is much harder to judge, because you're looking at needing just a small amount to cause an overdose.
Yeah, indeed. And would I be correct in thinking, and this is maybe a street term, I definitely bumped into, I think, a synthetic cathinone recently. Was it bath salts? That was, or certainly the street name for the synthetic cathinone, but absolutely was creating an ABD kind of almost manifestation, acute behavioral disturbance, and it's very tricky to deal with. And certainly something which prompted a lot of research from me, because I hadn't bumped up against these synthetic cathinones before, but very difficult to judge the quantity and quality of any drug like that.
Yeah, so I think the term bath salts comes from when these substances were legal. So pre-2016 in the UK, in order for a drug to be made illegal, it had to be named in the Misuse of Drugs Act and controlled. But in the early 2010s, that's when a lot of these NPS started emerging. And by the time you controlled one, it had gone out of fashion and people had gone on to the next thing. And so it was this sort of game of whack-a-mole of trying to play catch up, with the emerging substances. And whilst they were sold openly in what were known as head shops, they were listed as not safe for human consumption. And I think that's where the bath salts thing came from, as how they were sold. The other name I've heard for them, and I should probably Google this because I don't know why, is they also get called monkey dust as well. So, but I can't tell you the origin of that name, I'm afraid. I think there's two challenges here. So I think one is the potency. So the harm reduction advice that's given to people who use drugs is go slow, don't use alone, and carry naloxone. And that first one that goes slow, you might go slow, but if something's incredibly potent, the small amount could still be a fatal dose. And so that makes it the other two so important in terms of don't use alone and carry naloxone. And I've never treated anyone with naloxone myself that's suffering an opioid overdose, but I've heard of reports of people who have taken nitazenes in the past couple of years, that naloxone is effective against the nitazene overdose. But what might happen is the person might relapse into respiratory depression not very long after that initial dose. So they would need repeated doses over a more extended time frame than an opioid overdose from one of the other opioids that somebody might have taken. So I think it's important to know that it is still looking like it is useful, and naloxone is actually a really potent antagonist, so should still be effective. So I think the potency is one challenge with these NPS, but then the other one, which is a challenge for both the users and any healthcare workers that are then trying to treat these people, is actually knowing what it is that the person has taken. So we have a few sort of drug checking mechanisms here in the UK where people can say what drugs that they had intended to buy, and then laboratories will test them and tell them what actually was in what was purchased. And quite often it is what people expected when it's one of the more classical substances like heroin or cocaine or ketamine. But when it comes to the NPS, very rarely do they actually know which NPS it might have been that they've intended to purchase. So the nitazenes are one example, spice compounds or synthetic cannabinoids is another. People might know the class of substance they've intended to buy. And even if they do have that class of drug in their sample, the nitazenes range from being as potent as fentanyl to 50 to 100 times more potent. So within class of nitazene, there's this huge difference. And that's even if you're sold what you think you're getting, because you could be intending to buy one thing and be given something entirely different. And so that's a problem for a user to know how much to take, but then also for somebody trying to treat them. They don't know necessarily what's the best way to manage these people. In terms of an overdose, if someone is unresponsive and you suspect opioid use, give naloxone is about the only advice we can really provide, in addition to respiratory support and CPR if needed. I think the only other bit of advice in that regard could be that if the person doesn't want further treatment and wants to decline any further intervention, would be to try and at least give them some naloxone if that's possible at all to take with them. So they've at least got it either for themselves if needed, or if they come across a friend or a family member that might need it in the future. So it's difficult to say that there's a particular sign. It's just these people would have slipped into respiratory depression much more quickly than from a heroin overdose. But other than that, an opioid's an opioid in that regard, and that the signs and symptoms are going to be very similar.
So how would you differentiate, Caroline, just a first-time drug user from maybe more a dependent drug user, from a drug naivety perspective, or indeed how you just might approach them per se?
It's very difficult to be able to know a person's drug use history, and indeed many people who use recreationally are very unlikely to actually consider themselves dependent users, even though they might be using every weekend, or maybe multiple times every weekend even. And getting somebody to actually admit their drug use history can be quite difficult to do. You're asking people to acknowledge and admit to what is an illegal activity. So and people have these perceptions as to what what is a drug user in terms of, they might be using powder cocaine every Friday night, but they have a family at home and hold down a full-time job, so they wouldn't consider themselves a dependent user. So even within, someone that's using drugs recreationally versus dependently, there's a lot of grey area between those things. I'd probably say that quite a lot of the population of dependent drug users have most likely come into contact with drug services and or mental health services at some point in their life, and that's probably less likely for a recreational user. And I think the way to engage a recreational user the most is to not treat them as a drug user that's a criminal, but rather a person that is doing something that's fairly risky. And how can we make that situation less risky? How can we make that drug taking behavior safer? If someone's going to take the drugs no matter what, there's no point in sort of saying, oh well, you're out on your own then. What can we do to make that safer? And that's through education programs and improving user understanding in that regard. So polydrug use is a huge problem, and I think it's bigger than it's given credit for at face value. So looking at the database that I run, back in the early 2000s, the average number of substances that somebody had detected at post-mortem was between 3 and 4 substances. That today is up to 6 or 7 substances. And actually there was a case I was entering last week that had 24 different substances detected in toxicology. And these are people that are taking these substances in combination to try and tailor and tweak and augment the experience that they're getting overall. But in doing so, it's an incredibly risky practice. And equally, again, with some NPS substances, you might be buying what you think is a synthetic cannabinoid, but actually there might be 4 different synthetic cannabinoids in that preparation that you're giving. So you might think you're taking one thing when actually you're already taking 4. And that's before you've started taking anything else on top of that as well. So multiple stimulant use or multiple depressant use is risky for both cardiac and CNS function respectively. And we don't know that much about the pharmacology of these NPS as much as we do the classical substances. We don't understand what's called their pharmacokinetics, how long they last in the body, and their relative strengths, how are they excreted, all of these questions. And so in order to advise someone in terms of, how would you treat it or how would you use drugs, in combination with each other, that advice is really difficult to get because we just know so little about them. There are so many of these substances that are constantly emerging and we know so little about their actual action, and that's really problematic.
Yeah, indeed. No, indeed. Let's just look at really around emerging technologies to assist services in really identifying or monitoring or preventing harm from synthetic drugs. So your group is developing wearable sensors and indeed analytics and novel tools. Could you just speak to maybe these tools and indeed whether there's any barriers to implementation or whether they're quite successful in their implementation?
So the one that we're looking at trying to develop is one that detects the concentration of opioid in what's known as interstitial fluid. So you might have seen the glucose sensors that people are starting to wear now, which are a tiny little electrode that goes into the skin, and it's able to measure the fluid that sort of bathes our cells. And I think the best way I can describe that fluid is if you've ever scraped your knee and that sort of sticky clear stuff that's coming out, that's your interstitial fluid. So that's what we're measuring drug concentration in instead of directly in a blood vessel, so to speak. And there's a few of these wearable sensors that are coming out at the moment. The one that I've heard the most about is one that measures your O2 sats, your oxygen saturation. And if that starts dropping, that could send an alert that someone's going into respiratory depression from overdose. But I think, whilst that's good to have that alert, if you're already dropping your O2 sats, it's already bad news and quite late. And by the time the ambulance has got to you with some naloxone, you've probably not been breathing for quite some time. So the one that we're trying to develop is able to detect concentration of opioid. And so what we are hoping to be able to do is if someone was to be seen to have a rapidly increasing concentration of opioid, to be able to send off that signal that help is needed sooner than you get to the point of O2 saturation. So, but it's quite difficult to develop these things. We've got the science side, which is the part I would say that I would know about in terms of the actual measuring of the concentrations of the drug. But then the whole other side of this is, well, how can we link that into geolocation of the patch? So you have Bluetooth, you can Bluetooth the results to somebody's phone as the glucose patches do, but then how do you interface that much wider? And that's the part that I know is possible, but I know very little about that part of the sort of device development. And so what we're looking at is trying to expand the types of substances that patch could be used for. So not just opioids, but other stimulants as well. Cannabinoids would be useful. Other things like benzodiazepines, street benzodiazepines would be incredibly useful for. And it wouldn't just be useful necessarily just to for someone to wear to alert emergency services to. It would I've had some psychiatry colleagues say it would be really useful if someone's come into A&E and they're acting quite erratically and you're not able to get a blood sample from them. If you could just whack one of these patches on their back and sort of put them in a safe room and sort of then get the readout of what it is that's actually circulating in their system, that might be quite useful as well. So I think there's potentially multiple uses for it. We're not winning in terms of drug policy and emerging substances. The whole reason that the Psychoactive Substances Act was introduced in 2016 was in an attempt to try and stop the rapid emergence of NPS, because so many were appearing that they couldn't be controlled quick enough before people had moved on to the next one. But since the Psychoactive Substances Act was introduced in 2016, we've not really seen that much of a reduction in NPS, to be honest. And so the money that can be made from people selling these drugs is clearly a greater motivation for doing this than the fear of the penalties of if they get caught. And I think that we need to be shifting our focus. And I'm not saying we should decriminalize all drugs at all points. I certainly think there still needs to be an effort, particularly for manufacture and supply. Maybe less so for possession. But in terms of people who are using drugs, if we can reduce the demand for them, then by default, there's going to be less supply if you've got a lower customer base. And so we need to be looking at why is it that people use drugs? And I think, again, can we class people as recreational users and dependent users? I think for the dependent users, getting them the help that they need, very often there are underlying reasons why they are using drugs. It's not because they're doing it for fun. They're doing drugs to escape from some horrible reality that they're faced with, be that, past trauma or current situation in terms, if they're experiencing homelessness or incarcerated in prison. And if we can address the underlying drivers for the drug use, I think we would hopefully be able to help some of the dependent users. But then when it comes to the recreational users, these are people that enjoy using drugs because they like the feeling of taking them. And I think it's going to be much more difficult to say to them, look, X, Y, Z, these are the bad reasons for you using drugs. They know that using drugs is bad and not good for them. But they do it anyway because they like them. And so I think we also have to realise that we're never going to stop people from using drugs, but we can hopefully make that drug use safer. So in terms of sort of where UK sits within Europe with regards to NPS use, we're certainly the sick man of Europe in that regard. I don't know why, but for whatever reason, we seem to have a larger problem with drug use than a lot of European countries do. I don't know if that's a cultural thing from our perspective, or that when we're not as good as at educating or treating our citizens as other European countries are. I think that's It's a whole podcast in itself, I think. So we certainly seem to have a larger problem with NPS than a lot of other European countries do. Not saying that they don't at all, but we seem to have a bigger one. And in terms of regional differences within the UK, we certainly have more users and deaths in cities than we do in rural areas, but that's because just of the rules of population. If there's more people, there's going to be higher prevalence of things happening. But in terms of what we're seeing and where and why, it sometimes appears a bit random and a bit strange. And I think that really drills down to which drug gang is operating where, what their connections are with, and as to why we see certain substances. So we were talking about the bath salts or monkey dust earlier. We don't really see them across the UK, apart from in Stoke-on-Trent. Massive problem with bath salts in Stoke-on-Trent. Why? Difficult to say why they're so available there and not elsewhere in the country. I don't think there's a particular demand from the people of Stoke-on-Trent for them, but that's what's being offered on the streets. And equally with the nitazenes, the one of the first bigger incidences of where overdoses were being seen was in Birmingham in 2023. And again, why Birmingham in particular and not another country and not another part of the country? And so it doesn't seem to be very predictable as to where we're going to see what and why.
You're listening to the Pre-Hospital Care podcast on the Medics Academy Network.